Google Hangout Live. And of course, you can send us a tweet, and that's at Bart's MS blog. So, without that, we're in Sweden.
And on that note, let's start with the Swedish Registry. So the Swedish Registry is quite comprehensive. They've got very high accrual rate, so it is a very useful data mining set to look at treatment selection and treatment switching, as well as discontinuation as well. And if you show the slide, you can see there that patients are going through different types of treatments, and often it's very confusing what type of treatment someone is on.
Can I just say that the first one is the first treatment, the second one is the second treatment, and then the third one is what
it could actually, yes, but it could also include discontinuation and restarting as well. Now, the problem with real-time registry data is that often we think that these treatment selection actually has a criteria, but in fact, you find there's a huge influence from geographical distribution. So depending on what's most favored up in north, there's often a hotspot of prescribing around that drug, which you can see on the next slide.
Yeah, well, we're in Rituximab, that's it.
Yeah, so you can see that clear pattern of distribution, red hotspot in the top half of the country. So registry data, real-time data is useful in informing us about what's happening in real life, but you do have to interpret what you see based on what you know about the local population. Now, one of the things which has been quite topical with registry data is looking at pregnancy outcomes. And that's been very informative about medication. So, but what's also needed is to see what the actual definitions for inclusion into registries. So when we look at fetal malformations, for example, as a pregnancy outcome, are we looking at viable pregnancies, i.e. a viable pregnancy is defined as those who have evidence of a successful pregnancy at first trimester. Now, first trimester...
3 months.
Yes. And if you don't know that that is what's actually been included, you may in fact miss all the early stillbirths and also miscarriages. And as you can see in the second picture, depending on if you're looking at a registry or if you're looking at a small study or in the literature, the definition is very important as to how you analyze the final data set. So one of the things which was quite interesting with this year's ECTRIMS is that the main focus has been on progressive disease. And progressive MS increasingly has become more topical through various years. And now this year the focus was on progressive disease. And also our definition of progressive MS has been changing. So if we look at the recent clinical phenotype revisions, you can see that we're not thinking of primary progressive MS or secondary progressive MS in isolation. We're thinking of progressive disease as a whole. And we are in fact treating those with active disease and progression, those with active disease but without progression, and those who actually are not active but show evidence of progression. So these are the patient groups which we are treating. We are not actually now treating those who are not active or not progressive.
So you mean active, I guess, people who are having relapses or MRI lesions, is that right?
Yeah, that's absolutely correct. So I don't think we had over the last 2 years we were quite clear on that, but the progressive trials, both the siponimod and ocrelizumab, have been quite informative in allowing us to select the most appropriate patient group.
Okay.
So if we look at the siponimod data, one of the things which was presented was what is the risk of progressing from an EDSS score of 6.5 through to 7. So majority of our patients are walking in at that EDSS score. And what we're interested in is, can this drug prevent them from getting into wheelchair?
Okay, so saponimod, for those of you who haven't heard about it, it's a drug which we call a sphingosine 1-phosphate modulator. It's like related to fingolimod, which you might have heard of, but obviously saponimod is being licensed now in the States for treatment of secondary progressive MS, isn't it? So.
Obviously, we're still waiting to hear, but it would be interesting what the UK side does with it. So if we move on to what they actually found about that subgroup analysis of those who are going from being partially ambulatory into wheelchair, what they found, if we show the actual survival analysis, is that there was an overall 37% reduction in the saponimod group versus the placebo, which is quite nice to know that we can at least slow the disease down at the higher end of the EDSS. But what we did find is that if you included the overall study population, which also includes 5.5 EDSS score, that trend is lost in that, although there is a 30% reduction if we show that graph, it wasn't completely significant on the p-value. So the p-value was 0.0585. So what does that all mean? Why do we get this kind of difference when we look at a sub-study, but then when we include the whole data, we are in confusion? And hopefully this multi-state model actually shows us how these patients are transitioning. So if we show that, what you can see, and this is a bit complicated, this model, you've got patients who are under EDSS score of less than 5, and you've got then 5.5 through to 6, and then 6.5 and greater than 7. And what you have at the top are patients who are worsening, and the bottom you've got patients going in the opposite direction, i.e. improving. Now, when you say a hazard ratio of 0.79, it means that patients in the placebo arm were more likely to move into an EDSS category of 5.5 to 6. But then when you're moving from 6 into 6.5, you get the opposite, that more patients in the saponimod arm are moving across. And so this is obviously counterweighted by the movement of improvement in the opposite direction. So from EDSS 6.5 to back down to 5.5, the more likely that the saponimod group is doing that opposite trend in improvement. So this is clearly demonstrating something different in the EDSS assessments, but also in how malleable the disease causes with an anti-inflammatory drug. So interesting, we would need to see a lot more about this to understand how this is working, but interesting modeling done by on saponimod.
I guess one thing is you can still see people, the slope is still worsening. So I think it's telling us that although this is good, we still have got to do better.
Yeah, no, obviously we are looking for not only anti-inflammatory drugs, but also neuroprotective drugs. And if we can probably combine an anti-inflammatory drug with a neuroprotective, that probably is more the ideal scenario.
I mean, this meeting has been a meeting of the mods, I think, isn't it? There's obviously saponimod, and we've also heard of some new mods.
Yes. So
I guess earlier on this week we heard about the new data from pasanimod. Now, pasanimod is very, very similar to saponimod, and just to talk about what they are, how they work. Fingolimod targets these sphingosine 1-phosphate receptors, like there's 1, 3, 4, and 5, and saponimod targets 1 and 5. And why is that interesting? Well, one of the problems we've had with fingolimod has been little heart flutters, and it's thought that works via number 3, and of course Posonomod doesn't target number 3, and so it was quite reassuring in terms of the side effect profile that that issue wasn't really much of a problem. So I guess this is the appliance of science. So this drug obviously was working in relapsing MS, and it was working pretty well. And so obviously fingolimod's going to get a bit of competition, and there are other ones on the way as well. We're going to hear also about ozanimod, which is another one, and
we've had a question already about this. So someone's written in saying, "I'm in a wheelchair. Can I have the new DMT?"
Well, I guess what you've got to always wait for is you've got to wait for the regulators to approve these drugs. So what we hear this week is that drugs have worked, and then the companies have got to do a lot of work to actually get them approved by the FDA in the States and the EMA in Europe, and once they do, they then will describe what type of person best fits the drug, and that will then dictate how things go. So it depends on what the regulators say. Now, generally, most of the trials are actually at the kind of the lower end of, so people are generally a bit more ambulatory than being in wheelchairs. So that makes it more difficult for people in wheelchairs to get going. But we are in the process of doing trials that actually are interested in hands, because obviously hand function is very important, and there's things like oratoria hand, which is ocrelizumab, which is another drug which we'll talk about in a minute actually. So that's actually,
I mean, David, do you think with the introduction of siponimod that we actually even need something now for relapsing remitting MS? Why not just make it all into one disease and start everybody straight out on siponimod?
Well, that's one possibility. I mean, I think in America, where it's got license all the way through, from early MS all the way through to later MS, and that's, I think, it's partly biology, because we think MS is probably one disease, so there are problems of activity early on, they're there late on, and the nerve damage that we want to try and stop is there early on and late on as well. So it makes logical sense to me. Now the question, of course, I guess pushed to you is like, what with all these mods, how do we choose which one to use? What's going to happen?
Well, that's up to the individual clinician and patient. It's going to become a very complex, as you saw in the Swedish Registry real-time data. There's going to be a lot more swaps and switches. It very much depends on if the other drugs become quickly redundant once these drugs are introduced. So we may actually be culling the number of DMTs in the future, rather than in fact having everything available from the outset.
So it depends which country you're in, but I mean, at the moment in the UK, you have to have failed another drug before you can take fingolimod. Maybe with these new drugs, you go straight onto them. So why would you want to wait, I think?
Well, that's my question.
Yeah.
Siponimod for secondary progressive MS. Now, if we look at the ocrelizumab study data, and they presented in primary progressive MS, their 6.5-year data, which was also interesting in the outcomes they've had in the extension study. So if I show the analysis which they did, a bit different, but what they were looking at is the progression from time to wheelchair. So that's what they were looking at. So how long in each arm, the placebo arm versus the ocrelizumab arm, went into wheelchair, and then they had this interim period where people were all then swapped on to the ocrelizumab.
Yeah.
We've just been told that Hall F is live, so for those of you who are in the hall at the moment, just to say that this is the Google Hangout session, so we were delayed by the previous presentations in the hall. And we are here going through the actual summary of what we thought was interesting in ECTRIMS. Now, if you want to participate, I'll hand over to my co-host, Professor Baker, to let you know how to participate directly in this Hangout.
Okay, so if you want to send us questions, please do. You can go onto the Bart's MS blog, and that's www.ms-res.org. Or you can tweet us at Bart's MS blog. So please send your questions in, and
we'll try and answer them to our best of our efforts.
Yes. So welcome to Sweden.
That flag, we'll need to find it after the end, isn't it? Anyway. So we were discussing about the Oratorio 6.5 year data. If you would like to see the previous discussion topics, it's available on YouTube as well. So what they found was that those who started earlier on Ocrevus and had continuous Ocrevus had a more favorable outcome in their progression to EDSS than those who started on the placebo and then switched on to ocrelizumab. So you can see that on the right hand side tree graph, where you see that everything goes towards the right-hand side, which was quite interesting. And if we think about what else we have worried about, David, you mentioned the hand function, and they looked at this with the 9-hole peg test. Now, what's the 9-hole peg test, David? I mean, you've done this before.
Okay, so it's like a little thing with holes in. You have to take the pegs out the holes and then put them back in.
Yeah.
It's how quick you do it.
So in that, they not surprisingly found a similar but more discriminative finding that those who were on continuous ocrelizumab from earlier on did better than those who were on the placebo arm as far as the 24-week confirmed disability progression in the 9-hole peg test. So what do these two studies, siponimod and ocrelizumab, tell us? Which is, it's quite straightforward. I think it doesn't take a genius to figure it out. Not that we're not geniuses, but anyway, some might to differ.
No.
Anyway, so what that shows is that you got to go early with these drugs. You can't hang around, and time is brain. And this is not just for stroke. This is the same applies in MS. So it's important.
Yeah, and I think what this kind of type of data elegantly shows is, by not being treated in those early months, what you've lost during that time window, you stays lost. So, treat early, treat effectively, I think is the mantra, which we always stick to.
So we've had a question, which is, does siponimod impact on brain volume at all?
Well, you can answer that one.
So we need to know what the actual long-term findings on this study with regard to brain volume. It was favorable before. Also, the biomarker was stupendously favorable in terms of what I mean by biomarkers are the neurofilaments, the lymphocyte population depletion was also quite interesting, as was the depletion of the innate immune system. So we're getting a complete shutdown as far as the immune system is, or partial in some of them, but definitely in the B cell pool, it's a complete shutdown.
And it's interesting, there's been, again, work suggesting there are subtle differences between fingolimod and siponimod. And if you remember, fingolimod was tried in primary progressive MS and didn't seem to have activity. Now that may be because of how the trial was done. We've learned a lot more about how to do trials.
Yes.
And we're getting better at actually making trials positive.
Yes.
Because we know what to look for. Hand function being a good example. If we'd have used hand function as an outcome rather than walking, some of the other drugs would have
not have to be canned.
Yeah, we've had drugs that worked maybe a few years ago. Another one.
Are DMTs for progressive disease
the same
as for relapses? Well, interesting question. So it depends on whether you think the inflammation is actually causing demyelination or you think it's actually causing axonal breakdown. And if you think that the two processes are separate, then you may say actually that you may need different DMTs to target different things. Now, if you think they're all one thing, then yes, if the inflammation precedes the axonal breakdown, then you just have one pool of DMTs, which are all anti-inflammatory and immune depleting.
Yeah, well, I would subscribe, kind of that more to that model, and I think obviously I've been working with the little beasties, and we can see that type of thing. So clearly, I think there's the immune function that is driving a lot of the damage, but once the damage has been triggered, then there are other processes that keep going underneath it, and which means we need different types of treatments for that. But that's fine.
Yeah.
And I think one thing that was also evident from some of the work, which we've heard before, is that early amount of activity can kind of dictate to some extent when the kind of this slow continuous worsening becomes more clinically evident. So again, saying get on top of the disease as soon as you can.
Yes, it's a correct approach. I that's my take on it as well. As you're all aware that we presented from our team, from the Bart's MS, Dr. Malta presented the Proximus study, which was also quite interesting. David, would you like to explain about the whole study?
So Proximus, that was a name that was actually picked by you guys, and the idea of the study was to treat with a neuroprotecting drug. This one we used was called oxcarbazepine, which is a sodium channel blocker, and that's involved in how nerves transmit. And the idea here was that we were going to put this on top of a treatment. So the idea was basically we'll look for people who are on treatment, and then we do a spinal tap and to see certain markers suggesting that the disease wasn't under effective control, and that we would then offer people the option of having this drug or a placebo. And of course, it was kind of interesting because we kind of got things wrong. Now, this was
not the first time.
Not the first time, but we were obviously a bit ahead of the game because we were thinking about these things called neurofilaments, which we'll hear of a bit later. But what we did is we kind of looked at people in progressive disease, and you could see a certain level. So that's how they thought they would pick people. But these people were on DMTs. And of course, the DMTs are stopping nerve damage. And so most of the first people that went into the study were rejected because they weren't active enough. And so it took time for them to realize that actually the DMTs are protecting the nerves again. And so they had to change their kind of criteria and then to get people enrolled.
Yeah.
And they did the study, and they had the major outcome was these nerve filament proteins. Unfortunately,
they didn't see a change. Now, obviously, oxcarbazepine is a channel blocker, specifically a sodium channel, and we don't know enough about the dynamics of the filamentous proteins in the axon to know what the effect of sodium channel blockade does. So whether it actually makes it worse or makes it better, and which components are modified or in terms of their CSF release in a better way. So obviously these things are, we have to now take it forward. It was a very novel and very direct application of all the research we have been doing. So in a way that was a kind of a futuristic trial design, but we realized actually putting biomarkers into clinical trials, especially recruiting based on them, can have problems as using any other biomarker if you hadn't thought about all the factors which lead to the change.
Now that was the bad news. And the good news was, ta-da, in fact there was actually a clinical response. So although the biomarker didn't work, there was a slowing of the
EDSS.
surprisingly.
In progression.
And
so
a few people even did a bit better, didn't they?
Yes, so we're back to still having EDSS in clinical trials. Well,
And that was before we thought about hands, so we've changed our idea. And the other good thing, I think, which makes you think it might be real, is people's impression was also that their walking was improved as well.
Yeah.
So, it wasn't just the clinicians saying your movement's better, it was people who felt better. So I guess the question we'll have to put to the gang is what now? Because you can show, if you show an effect with 15 people, you're going to have to do another study. So, obviously, the funders, put your hands in your pockets. Okay,
right. So moving away from progressive disease, it wasn't all about progressive disease, and we did attend a couple of sessions on relapsing remitting MS as well. Not that we're now back to classifying the disease as different subtypes, but we know how treatments are developed. And one of the bigger talks was on HSCT, or hematopoietic stem cell transplant. This is where bone marrow mesenchymal stem cells are injected back into your body after they've been selectively pooled to kind of treat the MS disease. So your current present bone marrow is completely taken out of the picture, and you get a fresh set of cells back in. And so one of the big questions about HSCT was a discussion to see whether you would recommend HSCT or not recommend. And the questions which one of the speakers said was, you need to think, is HSCT efficacious? One, is it safe? And how much does it cost? I mean, obviously these are questions which regulators would want to know, and if you're going to try and get the treatment license, you better have these questions well answered. So one of the opening slides in the presentation, which we're going to show, was how does HSCT do in terms of NEDA? So NEDA response, as you can see in this picture, is that the red lines showing much greater NEDA response compared to the classical clinical trials, which are the blue dots in terms of NEDA. So NEDA stands for no evidence of disease activity, and is a composite measure between not only clinical outcome measures but also MRI lesion counts as well. And this shows quite clearly that HSCT is superior to traditional outcomes.
Yeah. I think everybody kind of agreed that the results with HSCT was kind of impressive. There was some discussion about the control arms to that, whether they kind of did kind of worse than you'd expect them to do. And so maybe the question is really how much better is it?
Yes, so one of the studies, I forget which one, which used natalizumab, and the rate of progression in the natalizumab arm at 2 years was much more than what was reported in the seminal trials. So when your control arm is doing much worse, then the difference is much bigger.
Yeah.
And therefore you may be overestimating the efficacy of HSCT. What about safety? I mean, generally we don't like to sell a treatment on safety, and but I think this is where it becomes very relevant.
Yes.
And the safety has always been an issue, in particular mortality rate.
And that's because when you remove your bone marrow with the drugs, that you're liable to infection. And really what the stem cells are doing is giving you protection against infection, and particularly your cells called neutrophils. And so very early on you're at serious risk of any infection, and that obviously can kill some people. Thankfully, I think the rate has really gone down, but it's not negative, it's not, and that's the thing.
Before we take the question from the online, just to show you the actual transplant-related mortality, which was published back in 2017, you can see that in fact pre-2005 the percentage was 3.6, and now we've improved in that the mortality's dropped significantly to 0.3%. And for those of you who are very highly observant, you can also look at the different types of regimen intensity at the bottom, and the low conditioning regimes, which are becoming quite popular nowadays, have almost zero mortality. So this is probably now flipping everything in favor of HSCT all over again.
Now, I think we've got to be, when you hear these things about stem cells, you've got to appreciate that there are different technologies. So one stem cell transplant isn't the same as another person. So bear that in mind. And actually, I just need to correct my colleague here. Is the stem cells were hemopoietic stem cells, not mesenchymal stem cells. We'll come onto those a bit later. So they're the ones that make your blood cells grow.
Yes. So going back to the adverse events as well, and there are some specific adverse events which are very typical for HSCT versus the control. So if we can show the slide, you can see that comparatively the post-transplantation infection rates were pretty comparative, but there were some specific things like the dermatomal varicella zoster was very specific for the hemopoietic stem cell, and also secondary autoimmunity. Now, where have we heard this before? I think we've been down this route with alemtuzumab, and this tells us that it's going to be an issue with HSCT as we start to perform it a lot more.
And I think it's because they work on a very similar principle. Both alemtuzumab, you delete your T and B cells, and obviously that's what you do with hemopoietic stem cells. And so I think there's a logical biology there. I guess you have the effect and the side effect. Now the question, of course, is how do the two balance?
Yeah.
Is alemtuzumab just as good as HSCT? Maybe we need to do head-to-head studies.
Yes, definitely. So what happens in situations when you look at a patient in particular? So there was a case presented which is a classic example of what they thought was where it might be a bit tricky. So if you show that slide, the example is of a 27-year-old woman who's had MS of 3 years duration, 1 to 2 attacks per year on platform therapy with active MRI scans.
What do you mean by platform?
Standard of care, like if you're on injectables, if you're on orals, if you are on, mainly secondary therapies. But if you can demonstrate that you failed that, then it's worthwhile escalating to more severe immunosuppressive therapies like HSCT. So the EDSS score was 2. So what they were saying is you had 2 options to go to the best available highly active DMT, or you go for stem cell. Now, if you look at the advantages on both fronts, they're both likely to halt relapses, and they do have good safety records. With HSCT, you are looking at a single treatment option. No one's been brave enough to go and repeat this one. But if you repeat it, the situation may change. The disadvantages is that with the DMT, you require ongoing treatment. There seems to be something like limited protection against the actual disease progression. So you may get rid of the inflammation, but you may not tackle the progressive disease. But the disadvantages of HSCT is that obviously you're talking about safety concerns, both short and long term, and any advantage against progression is uncertain.
Yeah.
So the people are breaking through 10 years after receiving an HSCT protocol. Now, this is what we call equipoise, so balance of advantages as well as disadvantages. And when you have a situation like that, wouldn't it be better just to go with the highly effective DMT?
Okay, so equipoise, just so everybody can know what that means.
So as I said, if you've got a balance and it doesn't favor one way or another, you may want to go with the lesser of the two evils.
Okay, Okay.
And that's where you have to decide, and your patient will have to decide as well. So interesting. And the third, which I mentioned about costs, at the moment all the trials are funded, so there's been zero cost to the patient. But in the future, it's thought that it may be equivalent to 2 to 3 years worth of a highly active DMT. All right, so moving away from HSCT, we've had a question saying, have you seen any cases of immunovigilance or monitoring for MSS on drugs like Tysabri long-term to prevent septicemia?
Is septicemia a problem?
No, not really. I mean, there are increased infections, as you would expect, from every highly active DMT, but hasn't been, because septicemia, often the issue is neutropenia is what leads to more likely subclinical septicemia, and can be quite dangerous. So far, these drugs luckily don't seem to target the innate population to that extent. Obviously, there are viral encephalitis, which can, if you keep the cells out, might be a problem. How would you prevent this? Let's take the biggest culprit, which is the risk factor for natalizumab, but Tysabri, which is PML. And for a long time now, there's been this talk of extended interval dosing to reduce PML risk, and I think it is going to become the norm in a lot of cases. So you de-risk.
There was an imaging study presented again this morning, which you might not have seen because you were busy working, suggesting that by having the extended interval dosing, there was no more disease activity in terms of imaging. So that's potentially a good thing. So obviously, if we can de-risk use of natalizumab, it's a very good drug.
Moving back into the stem cells, now about mesenchymal stem cells, which Carusis presented yesterday. And so he was discussing about intrathecal introduction of mesenchymal stem cells.
It's like a lumbar puncture type thing, isn't it?
Yes. So you introduce it. He compared it to IV introduction as well. So if you can see that picture of it, and what he showed was some very phenomenal data, which I'm still making my way through. But it's quite clear that the intrathecal introduction of mesenchymal stem cells was much more efficacious than the placebo arm. Which is blinded.
On the slide, if you're seeing that, it says MSC IT. That means intrathecal.
Yes.
And
MSC IV.
So and that's basically, the blue ones are people who their disease is stabilizing versus the red ones that are deteriorating. And you can see, compared to the placebo group, where it's roughly 50-50, most people with the intrathecal effects are basically stabilizing, which it would be quite encouraging, I guess.
And there are obviously cycle responses as well. So the placebo on that graph is in black, and then you've got the IV mesenchymal stem cells and the intrathecal, and really redosing a second cycle of intrathecal seems to give more superior effect. So this may be a potential treatment if it persists in showing this level of outcome.
Yeah, and I think the other thing we've got to say, obviously it's a single centre, and we want things repeating, because actually there was another study presented, and it was called ECTRIMS was the name for the test, and basically this was an intravenous dosing of mesenchymal stem cells, and this actually involved lots of centres around the world. And I think it involved over 160 people, and the results were presented by some my Italian chums, and unfortunately it didn't work. So it sends a word of warning to some extent, is that stem cells aren't necessarily the be all and end all. It's obviously how we do the trials will perhaps dictate what the end result is, but it does say you get stem cells. It is not going to make you run around walking again instantly. So you've got to have, you know, the a view of what these things can and can't do. They have lots of potentials, but we have to keep a realistic lid on it. So that's a bit of a downside, but I thought that might happen. Also, the animal data wasn't as strong as it could have been. You know, and compared to the current DMTs, it wasn't that good. And so, if you're looking for an effect on relapses, and we've got treatments, very effective treatments. So you shouldn't really be thinking about that type of stem cell for those type of treatments, I think. But
okay. So you also attended, I know our audience members are always interested in remyelination. So you attended a large session on that. Would you like to tell us about what they had to say for themselves?
Yeah, it was quite interesting actually. So I guess what we all want, we know that one of the main problems in MS is demyelination, and obviously one way of making the nerves healthier is to get that myelin back onto them. So that was the question. But there was, the first question really is what is demyelination, what is remyelination? And there was a study actually by a Swedish group, and what they've done is they've looked at the radiation caused by the atomic bomb tests. And from that, they can actually work how old your myelin forming cells are. It's like carbon dating on single cells, quite amazing. But what they suggest is that if you look in what we call a shadow plaque, that the cells...
What is a shadow plaque?
Oh,
do we know?
Well,
okay, you're about to tell me.
I have a picture of that. We've got a little friend who's got that. And so here you can see these two blobs, or two holes, and that is demyelination where you see the yellow. And on the one on the right, you can see this kind of, it's almost like a thin hair, where it's less pink. And the pink is myelin, and you can see this little rim on the top. And what they think there is that's remyelination. And what the interesting thing has been, of course, is at this meeting, this has been questioned. So
so you're going to question about how many 10 years plus worth of neuropathology data in one session, is that?
Yeah, well, I think the reason why this is interesting, because what they have suggested is in the humans that the cells in these shadow plaques are old, not new. And so all the idea is that you have these oligodendrocyte precursor cells that come in and make the new myelin. And that's what we've shown from all our animal studies. So this is kind of questioning it. So one question is have the pathologists been right? Is it really remyelination? And
I think I'm not quite sure how a shadow plaque could be a partially demyelinated lesion. I think it would be very difficult to prove that. Is there some kind of change which makes a shadow plaque partially demyelinated as opposed to a normal MS lesion which is fully demyelinated? The logic tells us that it's probably sensible that if there is macrophages gobbling up, they'll be enhancing remyelination at certain points, and you will start to see partially remyelinated lesions.
Yeah, well, I think obviously we know that there is the gold standard, and that's you do a thing called electron microscopy, and you can tell myelin and whether there's been myelin replacement. I think the issue has to be sorted out, and probably what needs to be done is the Swedish group have to be given blinded samples somehow, and they then we work out really what the truth is. And that's scientific progress, because obviously it is a question. Now we've had a question come in. It says, is neuroprotection the same as remyelination? The answer is no, not necessarily, but yes. So what we think is obviously if you get remyelination, which is going to repair the nerve, that will make the nerve be healthier and less likely to die.
So are you then implying that your own body will go and myelinate that said protected nerve? I mean, that's a bit of a huge leap.
Well, I think what we know is that if people have an attack, and especially early in the disease course, you do get recovery. And so one of the default mechanisms is that you do get repair. And I think early on with alemtuzumab, for example, it showed that people's EDSS actually got less. So I think there is a natural repair, and in the animal systems, that's the default pathway. But obviously with time, and as you get older, that those repair mechanisms fail. And again, we've seen a number of presentations showing that age matters. So that's obviously one of the features that kind of predisposes you to a kind of a worse course in the future. It's how well you can repair. And as you get older, unfortunately,
you are losing brain.
Yeah. And
my okay, so if I respin that question, is axonal protection the same as remyelination?
I don't think so. I think, and
So
I think this is what we've been doing, or what was done with the Proximus study. The idea is you try and help the nerve to stop whatever may drive some of the damages, and in that time, then you would hope to get a remyelinating therapy. So I think in the long term, I personally believe there'll be a therapeutic cocktail. So you'll clearly have to get rid of the inflammatory drive, and then you'll try and protect the nerves that are surviving, and then you'll try and repair them. And that will be remyelination, and probably not too science fiction is maybe to try and improve nerve branching and resprouting, and so that's a bit for the future. But nevertheless, I think that's where we will be heading. And certainly in terms of the remyelination, again, there's lots of different studies ongoing. There are lots of new ideas, and there are lots of different remyelinating agents that have been shown in this meeting. Too many, and there are trials ongoing, but there's none that I can kind of report the results. There was one trial that is nearly completed. Unfortunately, they didn't actually tell us what the result was. And there's another study that's ongoing in Canada using hydrochloroquine, which I guess... Hydroxychloroquine.
Yeah.
And that is what they say is past its futility. So it means it's still got legs and it's still ongoing. So it's a question of going to be watch this space. But clearly that space is being filled. And I say there are lots and lots of ideas. It's how we do the trials are going to be key.
The biggest contender at the moment is lipoic acid, isn't it? Okay, so swiftly moving on, I think we can't finish a session without actually reporting on how alemtuzumab is doing.
Oh, yeah.
Yeah, so we recently had the 12-year data on alemtuzumab, and it's looking good. If we show it, you can see that the CAMS 223 study, which was then extended into Topaz. So it's showing that the annualized relapse rates in the groups remain sustainedly suppressed.
Yes.
And if you look at their EDSS changes, the stable group is fluctuating, but it is kind of similar. But then when we move on to looking at 6-month confirmed disability progression, then I think that needs a bit of work. You can see in that curve, the patients free of 6-month disability progression are steadily dropping. Now, the thing about the study, the CAMS 223 study, they were recruiting people with a EDSS score less than 3. So if you look at that, there were some patients who were already probably progressing as they entered into the study. Now, if you look at the 9-year MRI data, again, you're seeing very good outcomes in terms of MRI activity in the long-term group and GAD enhancing lesion-free activity, as well as neuroenlarging T2 lesion load. But then you come to the brain volume loss, and you can see that there is this steady petering, although probably not majorly significant, of continued brain volume loss. So
yeah, but my brain's shrinking too.
Well, we can't do anything about that. But anyway, but maybe no, I won't pursue that thought. So, as you can see, ladies and gentlemen, that the anti-inflammatory efficacy over long term, it's questionable whether it actually leads to proper neuroprotection or getting rid of the neurodegeneration, which has already started at day one of this disease.
But that kind of says, well, maybe we need something that's highly effective very early on. So, I mean, where are we with alemtuzumab? Do we know?
Well, I'm told we should hear in October. So it's that watch and wait space for all of us. And we are sitting there for the last couple of months waiting to see what the EMA's decision on alemtuzumab. As you know, in the US, it's already third line, but in the Europe and in the European Union, it has been used as first line with very good outcomes in patient groups. But since then, we've all now been using ocrelizumab.
But it's funny, isn't it? There was a poster about how much monitoring you have to do, and how does that influence what you do?
Yeah, if you can show that. I mean, yes, in terms of if we go back to our old platform injectables, they were very much not very labor intensive, whereas the newer treatments are definitely labor intensive, which affects the way we do everything. So swiftly moving on, because we've got about roughly under 5 minutes left, is to just talk about the serum neurofilament, which has been again a hot contender in ECTRIMS this year.
Biomarker central, isn't it?
Yes. So in terms of whether there are any comorbidity associations, there was an interesting original paper presented showing that there wasn't any sex or race differences. But if we go on, they found that in the people who are diabetic, there seemed to be an association with higher serum neurofilament levels. And then in those who were obese, if you had less fat on you, you tended to have more axonal breakdown. So I think some of us has to look at this in a little more detail. And then obviously that was interesting, and I was still trying to digest that, and so were you by the looks of things. And we talked about what was the predictivity of the neurofilament test. So a lot of the hypothesis about, is it inflammation related? And so someone looked to see whether it's more indicative of past disease activity or future disease activity. So they tried to model this using serum blood levels, and what they showed is that serum neurofilament levels normalizes within 3 months of GAD-enhancing lesions. But if you move forward, it didn't predict future clinical relapses. So I'm finding it difficult to marry that with serum neurofilament being prognostic in terms of disability progression in the future. So obviously we need to look further.
So we've had a question, and I can put it to you. It says, which scientific research paper addresses the importance of neurofilament and oligoclonal bands in CSF as biomarkers in MS? Which one's the best one?
There are lots of review articles on both. I think the easiest recommendation I can make is go into PubMed, put in neurofilament light chain and oligoclonal bands as a composite, and look at all the reviews. And there's a couple of them which have been done recently and are free access as well. So if you're interested in that, go ahead and have a look.
Okay.
Now, this morning's session was also very interesting in that someone presented on whether serum neurofilament can actually predict the diagnosis of MS. So if we show that, what they found was that a rise in neurofilament leading to at time 0, the first MS symptoms, in fact pinpoints the actual onset of MS. Right. And in fact, if you take it out as far as, in some cases, on average, a majority of them are -8 years, you were seeing a similar rising trend leading up to the point of diagnosis. So that's hot off the press this morning, and has actually been published this morning as well in JAMA.
All right.
So very interesting data.
Someone needs to do a trial where they inject OPCs and see what happens. Okay.
There was a follow-on, would some reach the brain even?
Well, I think,
Yeah.
obviously we know what's happened in the animal studies. The question is what would happen in the human studies,
Yeah.
and that's what we need to do. The question, of course, is that the best way of doing it, or can you use chemicals to, change the OPCs that are already there? So I think we haven't got a lot of time, so can we move on a bit?
I think we're reading to the end of it, really,
we've got 5 minutes left.
Should we talk about one of our left-wing posters which we saw?
Okay.
I thought this was quite interesting. It's a poster which we came across which reported 3 cases of tumor-factive MS in cocaine users. So obviously I'm still quite thinking where is this coming from, but in fact it's quite interesting that we do have this as a potential risk factor now. So not only infections, but lo and behold, cocaine might be a risk factor for inducing autoimmunity. So watch the space. Now, we've also had a question. Any news from gold nanomaterials? No, I don't know what that is.
I don't know. The thing is, we can't go to everything, so
yes,
there are thousands of presentations, and I'm sure somebody can tell us about clean gold nanotechnology. I don't know.
So I think overall, this has been a phenomenal ECTRIMS sessions. As I said, the focus has been on progressive MS, but we've also had long-term data reported in all of our most highly active relapsing remitting therapies as well. And so interesting times. I think we're going towards now early treatment as well as high efficacy treatments, which may make it much easier in the future in terms of sequencing of these treatments.
Yeah, because I think the landscape is just going to get harder and harder, isn't it?
Otherwise,
in terms of the choices are going to get bigger and bigger.
So, David, where are we next year?
Well, next year, hopefully, if you approve, we'll be back. We'll be back, and because we're hopefully going to the USA, because next year
we're joining with ECTRIMS.
ECTRIMS, so it's in Washington, D.C., apparently.
Yes. So it would be interesting to see what the follow-on from what has been presented at this year's ECTRIMS. There'll be some new trials which would obviously be presenting. So again, there's going to be a lot of stuff to present, hopefully.
Yeah.
So I think on that note, we would like to say our farewells. I am not sure what's happened to our flags, but anyway, I think I'll just have to use my hands and wave at the audience and say it's been great being at ECTRIMS in Stockholm. It's a beautiful city, and we've had a wonderful time in figuring out what to do with our time.
There you go. And hey do.
Hey.
And that's goodbye from me.
And goodbye from me.
So see you next year, hopefully.